Hi everyone, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. I'm excited that Dr. Franklin Gaylis is joining us. Franklin is Chief Scientific Officer of Genesis Healthcare Partners, an integrated urology group, and he's also a voluntary professor of urology at the University of California in San Diego. Franklin has really distinguished himself internationally and on the subject of medical quality. He actively pursues cutting-edge research on quality improvements and methods to optimize clinical outcomes. Franklin's going to spend some time with us going over some of this research and his publications in the last few years. Franklin, thanks for joining us.
Thanks so much, David. Greatly appreciate the opportunity to share some thoughts as to how we can leverage the electronic medical record to improve medical quality. By way of introduction, I think we should reflect on how the United States healthcare system is transitioning from volume to value. And this started with the Medicare Access and CHIP Reorganization Act of 2015, unanimously approved by Congress and known by the acronym MACRA. And it covers the Medicare Improvement Payment System and Alternative Payment Model, APMs and MIPS. And the goal is to improve the value of the services we clinicians provide, trying to provide better quality at a lower cost. And there's an old adage in the field of quality which goes as follows: you can't manage what you can't measure, and you can't improve what you can't manage. Therefore, one needs to measure in order to manage, in order to improve. And this shift to value will require data for reporting adherence to quality measures. We should take note of the cost of reporting quality. And this is an important study from Health Affairs published several years ago, which looked at the cost of quality reporting for individual physicians in 4 common specialties and determined that it takes about 785 hours per physician per year of time for a total cost of about $15.4 billion dealing with the reporting of quality measures. And on an individual basis, the time spent by physicians and staff translates to an average of about $40,000 per physician per year. Now, while much is to be gained from measuring quality, this current system is unnecessarily expensive, and I believe we should make a greater effort to standardize the measures and make them easier to report at a lesser cost. With this in mind, we at Genesis Healthcare Partners, an integrated urology group here in San Diego, undertook a study to improve clinical staging and risk stratification of prostate cancer. We wanted to see, could we determine the exact recording of digital rectal examination, which we, and I certainly believe, is important and relevant. And this is reflected by studies done by Dr. William Catalona several years ago, who concluded that the DRE used in conjunction with the PSA enhances early prostate cancer detection. And another study in patients with normal PSA determined that the DRE, the digital rectal exam, has independent utility in detecting clinically significant prostate cancer. And we should be reminded that the AUA and NCCN guidelines apply clinical staging, the digital rectal exam findings in the prostate cancer risk stratification models, as well as the fact that clinical staging is necessary for certain quality measures, such as PQRS 102, which is a Medicare quality measure measuring the number of bone scans performed for those patients who are deemed low-risk prostate cancer, as well as AQUA quality measure number 9, the AUA's AQUA system, which looks at the adoption of active surveillance or watchful waiting, conservative management for low-risk prostate cancer. So one can see that the denominator for both these measures is low risk, and we know that clinical staging constitutes part of low risk stratification. Now, if one looks at the electronic medical record or even our paper charts from years gone by, DRE documentation is quite variable, not very specific. And we'd often see the chart notes state that the patient has a hard prostate, an indurated prostate, a nodular prostate, not very specific as to the degree of involvement in the prostate by clinical exam. And sometimes one would see schematics, as I've indicated on the right-hand side. And if you look at that oval shape on the right, is that a T2B lesion or could it be a T3A lesion? So again, not very specific. With this in mind, we undertook a study to determine if we embedded the American Joint Commission on Cancer's tumor staging template, sorry, it's the American Joint Committee on Cancer's tumor staging template to define explicit documentation of DRE findings. And I bring your attention to T1C, which we know is a benign, normal, smooth prostate without any nodules or induration, or T2A, an abnormality, either a nodule or induration, which is confined to a half a lobe. So it's less than half a lobe. So this is very precise clinical staging. And we wanted to see if we had our colleagues use this template, could we improve the quality of documentation of the DRE findings? And what we found here, and which was published in Urology Practice some time ago, is that when we look at the blue bars of this histogram, those were the data from before we introduced the template. On the left-hand side, we see recorded confident explicit, where we could tell confidently there was explicit documentation that the patient had a, say, a T1C or a T2A lesion, and that we could only find in about 16% of all patients we looked at in the cohort prior to implementation of the template. Post-implementation, with education of our colleagues and requesting that they use the template, that explicit documentation improved to 60%. And then we looked at combining implicit plus explicit. So implicit would be if a physician recorded a normal feeling prostate, we'd say that that's equivalent to T1C. And one can see again that before and after, there was a significant improvement from 74 to 92%. And most importantly, if you look at the right-hand side, the blue bar is 26% in the pre-implementation phase, where there was no way of telling what the physician had identified in terms of the DRE findings, in contrast to post-implementation, where 8% of patients we couldn't detect any clear information as to the DRE findings. So that was another statistically significant contrast, documenting that the DRE template certainly improves the quality of DRE documentation. And in order to get our colleagues to utilize the template, we started publishing what we call audited feedback or comparative physician reporting, where we showed each physician compared to everyone else in the group. And at the time, we anonymized the names, so there was no actual names. Today, we are more transparent with actually putting in each physician's names. And we set some thresholds, and as you can see, there's red, yellow, and green. And one can see the trend from poor performance or poor adherence in the early days of 2017 over a 3-year period. The majority of physicians trended to utilize the template and provide us with explicit documentation of the DRE findings. So in conclusion, risk stratification is important in managing patients with prostate cancer. In order to risk stratify, we need accurate information. Accurate assessment of the tumor stage by the AJCC template is important in risk stratification. And we've shown that one can leverage the electronic medical record with embedded templates to help in accurately acquiring the data. And this is going to be useful for reporting quality measures. So thank you for your attention.